please. Thank you. In a polite way. Shabab, I was told that I have to give this presentation, and everybody's going to hate me for this presentation because it's short, it's direct, and it's easy to learn. شفتوا الخمس ست محاضرات السابقة or the last 5-6 lectures that I presented last time. It was all condensed. Everything is 70 slides صراحة مقرفة وأنا أكيد انسبيت من أكثر من واحدة فيكم. I'm really sorry for that. So I made 74 slides, as you can see over here, that has everything. Okay, that doesn't mean I'm not going to get something from the other slides. No, you have to go through them. But you have to read those things. Those are the initial things that's straightforward, that we talk about it. Okay, and today, only today, at around 9 a.m. or at around 10 a.m. in the morning, I had a phone call from a landline. When you have a phone call from a landline, not a mobile, it's either good news or a bad news. يا إما البنك or a credit card, why you did not pay your bill, which is the most common. Or on the other side, somebody else is calling you to tell you that I was selected today only to be the chairman of the resident orthopedic in the Saudi Arabia. Who's going to come under my hand, okay? And I don't know why did this thing happen. It happened out of the blue, زي ما يسموها, okay? So the thing is that I'm in the clinical, I'm going to be the evaluator, and واللي هيطلعوا من تحت يدين الله يعينهم, because I'm not going to be an easy person. We smile, we joke, we have fun, but you don't know what's going to happen in the future. Okay. So the thing is, right now, this is my last presentation for today, or for this year actually. Hopefully that you enjoyed the orthopedic. Hopefully that there will be some people who has changed their mind from round, okay, to action directly and have a result. So the slides are exactly the same as the previous one. They are exactly there. I brought them from the from the previous 5 or 6 slides of presentation that I gave you, and they are actually. And the reason why I ask for male and female, because I don't want to say bad things about male to female, and I don't want to say good things to male about the female, okay? So I want to say bad about male, okay? But anyways, okay. I can see over here right now, from a first look, I can see 3 or 4 orthopedic surgeons. Over here, I see only 2, honestly talking. Okay, but over there, I can see 3 or 4 people that are keen to be an orthopedic, okay? And just today, okay, or actually last يوم الخميس الماضي, okay, or yes, last Thursday, I did a case. It was really a very nice case, okay. A guy who had a gunshot wound. You know, you've been studying about the gunshot wound, okay. What did you study about the gunshot wound exactly?
The gun itself?
Yes.
And the wound itself.
When you have a gunshot wound, the bullet, when it touches the bone, when it penetrates the skin and breaks the bone, what will happen to the bone? Who said comminution? Excellent. That's going to be comminution. And there will be loss of fragments, and there will be no clapping right now. Today, خلاص ما شاء الله. Comminution. And what will happen to that bone? How are we going to fix it? Me? Say it. Please say it loud. We're here to learn, guys. Okay. You said something. Internal fixation. Internal fixation is out of discussion, because internal fixation, you cannot apply it for an infected wound. Okay, number 1. Internal fixation, you do not apply it for a penetrated wound. شيء جاي من برا, penetrated the skin. It's infected from outside, passed through the bone and went out, or sometimes stays in. So those things, nah?
I will not do something. I will let it heal.
Let him die?
No, heal by itself.
Bone graft, not now. You have to do something first. Vascularity intact, كل شيء كويس, كل شيء. Number 1, take the bullet out. Number 2, remove the number 2. That's exactly. What do we call remove the small fragment? It has a name. That has a terminology. Thank you. It's called debridement. or in French, débridement, okay? That's why the French, it's an English word, but the French say it in a French way, but it's an English word, it's a debridement. And irrigation with antibiotic. خلاص, irrigation is done, debridement is done, bullet is out. What should you do next?
You make sure the vasculature and nerve...
It's intact. Everything is intact. You make sure, خلاص. Now, it's time to fix what you're gonna do. There is a loss of bone. Bone graft contraindicated. Why? Now contraindicated now at this moment.
Because there could be an infection?
Thank you. Who said that? That's great. There could be an infection. There could be, because it's a bullet that came from outside, and sometimes the bullet itself that can explode, and those things can leave some particles that you don't see it. If you apply internal fixation, what will happen? Thank you. Bravo عليكي. Osteomyelitis, infection, pus, discharge, non-healing, okay? So in this moment, that's what will happen, okay? I hope that I can show you the pictures. I operated on Thursday on a guy who had a gunshot wound and he lost around maybe 7 centimeters of his bone. So the doctor did something. He thought that he's a smart guy. He brought an IM nail and he stuck a nail in his ankle, in his tibia. What happened? The patient is 1 year after the surgery. He cannot walk. The bone did not heal. And it's not only that. The wound is open for the last 1 year and pus is coming out. What do you do in this moment? هلا دكتور. معلش انا لخبطت ميل فيه انا كنت بالنيل الله يطول عمرك حبيبي الله يخليك. What would you do right now? حرام عليك.
Antibiotic.
You have to stop here, okay? I will amputate you from this course, okay? Never do that. Would you do that for a brother or a sister, 25 years old? Never do that. Number one, bravo عليكي, remove the nail. Why?
Because it can cause...
Spread the infection.
No? لا, it's a sterile nail. A nail دخل sterile.
It's impinging the movement.
Thank you. That's the word. It's a foreign body. A foreign body inside an infected area will never heal, will never do anything, will never. So it was really disaster. So what I did, I removed the nail, I removed the screws, I removed everything. I'll try to show you the pictures right now. Actually, they're on my phone. I can. And then what happened? The pus, there was gush of pus came out. كمية pus غير طبيعية. Okay. The patient was extremely in pain for the last 1 year, and now how will you fix it? No more nail. And the wound is not closing. طيب, now I will treat the infection. How you will fix the bone. By the way, what I did is a case report and needs to be written. Okay? I'm proposing right now, I need 2 people. From now. لا تتضاربوا, okay? It's a case report. This has never been done before, okay? I took the nail out. The nail was debrided, cleaned completely the area. And then I brought the external fixator. We applied the external fixator. طيب الجاب هذا اللي هنا, how are you going to deal with it? That's number one. What type of bone cement? Antibiotic bone cement, we can apply it. But I don't want to apply anything. I want it to clean, debride. So what I did for him, we broke the bone from this. أحد بيفهم بالكمبيوتر. Can we shift it from here? في بلوتوث هنا ولا ما في بلوتوث؟ How do
Doctor, go back to the first cup. No, okay.
أحس وحدة جرسة.
And then what's up? What's up?
أيوة. Just scan. Sorry.
You see? So let's give it some time until the end of the lecture. Okay. Today, let's talk about something we spoke about it, and I would really love your interaction, guys. Okay, I would really love if you can talk to me and tell me about everything. You're gonna cut it short. We're not gonna stay for 2 hours, I promise you, but we're gonna take it short, but we need everything to be interaction. So we spoke before about sports medicine. We spoke about the common adult lower limb and upper limb sports injuries. Our goal as physicians, your goal right now is to improve, to recover, and to prevent injuries. We help regular people, not only athletes. And we spoke about the joints, type of joints. طبعا هذه الأشياء you have to know it. Okay, it's basics. You have to understand them. We might ask you in the question, what is this joint? What is that joint? So just you have to know it properly. We spoke about the dislocation, subluxation, and we spoke especially about the shoulder. Rotator cuff, you have to know what are the rotator cuffs, where they start from, where they originate, where they insert, their action, their blood supply, and all those things has to be taken. We have to know what's an impingement, okay? How do we treat it, and how to diagnose it. طبعا هذه الأشياء هي it's painful abduction, internal rotation. I do have this thing, okay? This thing you have to understand it properly. Rupture, what's the meaning of rupture, partial or complete? How to deal with it? I'm not going to ask you what surgical technique you're going to deal with it. I'm not going to ask you what type of anchor you're going to deal with it. No, it's going to be very simple. How to deal with it, surgical, non-surgical, conservative. My mother fell down last week only. This is really funny. I told you about it, didn't I? Yeah, okay, she fell down. She was admitted under my name, but I did not operate on her. My colleague, his name is Dr. Wasim al-Bayyan, I'm really thankful for him. I operated on his relative, he operated on my mother. Okay? So my mother, she had a supraspinatus, subscapularis, infraspinatus, and biceps tendon tear only. Only. She has 4 out of 5 tendon rupture. Operated, she's 1 week right now, post-op, doing great, alhamdulillah. Symptoms and signs, okay, you have to take care of it, okay. This presentation was done this morning, okay, and I drank my coffee, so it's very obvious. So, and then how to treat either conservative or surgical, and those things has to be taken to understand them, because this is the way how we deal with the rotator, with the shoulder pain and shoulder symptoms. Most important part, most common questions, shoulder dislocation, anterior shoulder dislocation, what do we call it? Okay, traumatic unilateral dislocation with Bankart lesion. Anterior is called Bankart, posterior it's called?
Kim lesion.
Thank you. Okay, male, please guys, okay? Tara, your voice is not aura, okay? Please speak forward, okay? I need to hear your voice, okay? It usually the mechanism of injury, the percentage of recurrence in young people. This is a very important slide. This was written in a chapter in book. I am the one who wrote it. It's in a Miller book, one of the international books, and it's available. And this is the present, you have to know it, from 70 to 95% in less than 20, 60 to 80, 20 to 30, 15 to 20 in more than 40. This is your field. This is where you're going to have a lot of questions. Anatomy, anatomy, anatomy. What is the function of this tendon? What is the function of that tendon? What is the function of the labrum? You have to know it, you have to understand it. Some of them are written over here. Some of them you have to go back and read about them. مثلا supraspinatus, the function of it. Okay, labrum, okay, shoulder capsule, what is it? Those are the things that you have to take it seriously. Mechanism of action, okay? At your level, you're not expected to operate. You're expected to understand the philosophy. Why did this thing happen? Why did the shoulder dislocate? Why? So those things, abduction. Or not this way, abduction, this is not abduction, okay. Abduction, external rotation is the anterior shoulder dislocation, and has to be taken how to reduce it and how to deal with it. This is the lesions associated injuries with the Bankart lesion, with the anterior shoulder dislocation. Those you have to know them by heart, okay? Yani when you go back, inshallah, even if you're not here in Saudi Arabia, anywhere else, okay? Anterior shoulder dislocation, even you're a family medicine and you said, oh, he has a Bankart lesion. Oh, how does she know about Bankart lesion? This is something really good. It's going to give you a good feedback. Not necessarily that you're an orthopedic surgeon. Bankart lesion is a general word, okay, that happened. And when there's Bankart lesion, there's a Bankart surgery. This is not you, okay? When you're an orthopedic, I promise you're going to, but it's one of the most interesting surgeries ever, the Bankart surgeries. How to reduce it? Associated with what? Hill-Sachs lesion. Hill-Sachs lesion. How to diagnose it? Where does it occur? Does it happen at the anterior part of the glenoid or the posterior?
Posterior superior.
ليش? Associated with what?
الجلينويد the rim.
Impingement with the glenoid. As you can see in this picture, it's very clear. Okay? So this happens usually. That's why we insist in young people to do the surgery soon to avoid any further complications. La samahullah. Most common nerve injury, axillary nerve. Okay, how to deal with it? How to have it? What do we call whenever it happens? When it's not ruptured. It has a nerve. It has a name. Neuropraxia. برافو عليكم. في شباب ما في. طيب, axillary nerve injury. This is something happened. Okay, how to reduce it?
Not the obstruct way. شو اسمه هذا؟
What do you-
We will take a rope and one will.
Traction, counter traction. Traction, counter traction. This is how you reduce it, okay? You try once, if it happens in the field, if it happens anywhere, okay? Ask number one, did it happen before? Yes or no? If it happened, sometimes the player himself will reduce it by himself. Otherwise, if it happens for the first time, okay, try to pull. Put the frame, as you can see on that picture, and somebody is pulling him. You are always the surgeon or the physician or anybody holding the hand, and the other side, somebody else, muscular, to make sure that he doesn't come with you. After the reduction, what you're going to tell him? Can he go back and play? What you're going to tell him? Now?
He needs X-rays to make sure that it went back to its place.
Excellent. I love that. طيب شفت يا شباب تفاعلوا شوي خلينا نصفق.
Doctor, I have a question.
نعم.
In this lecture, like in this way, in traction and contraction, I didn't understand the كلمة إنه affected limb. You have to pull it down and in lateral 45 position.
The affected limb, you're putting it down. Look at the picture when you're putting it over here,
Yeah.
because his hand is that way.
Yeah.
You're putting it down. Okay, ليش؟ لأنه when it's dislocated, it's anterior inferior. So I wanted to pass the glenoid. So we're putting it down, and when you pull it down and the capsule stretch, it's going to come up. It's going to go back in.
What do you mean by laterally?
Lateral. This is lateral.
Yeah.
This is medial. You're not going to pull the hand medial.
Laterally and down and laterally.
Down and laterally,
Yeah.
okay, and then whenever it's reduced, you externally rotate it later on and reduce it to its place. Posterior shoulder dislocation. We went through it. You see the previous lecture. نعم تفضل.
توب
about amputation.
So?
حق الامبيوتيشن. نعم.
So الحين لما when you see a patient when a person who's injured that you suspect has an anterior dislocation, you need to do the amputation sign examination on that.
هلا patient will never come to you in a quiet phase. If he has a shoulder dislocation, everybody gonna hear. He's gonna be screaming of pain. He's gonna have severe pain. But if he will come to you with recurrent shoulder dislocation, I want you to fix my shoulder because it's popping out every time. When you do the apprehension sign, all those things, he will be very resistant. So when you want to do AB adduction, external rotation, he will resist you because it's going to pop out if you externally rotate it. So dislocation will happen usually in the field or in the battle or anywhere else, but patient will not come to you quiet with shoulder dislocation. You're going to see them in the ER mostly. The posterior shoulder dislocation, تذكروا المحاضرات كانت واحدة هنا وواحدة هنا. Right now I joined them together. Okay, this is just the brief. This is the headline. What you have to know about the posterior shoulder dislocation and how to diagnose it. It is less than the anterior shoulder dislocation, and usually it's posterior inferior. And as I told you, it happens in two things. With حط اصبعك ويجيب لك. So this is the thing, trauma, okay, may lead to labral tear, seizures, and electrical shock. As I told you, it's the opposite of the abduction, external rotation. It's flexed adduction and internal rotation of the shoulder. Presentation, pain, trauma, okay? But if you expected a posterior shoulder dislocation, do not try to reduce it in the field, okay? Take them, sedate them, relax them, then try to pull it slowly and reduce it. To avoid
النك fracture.
fracture. head fracture.
ايوه head fracture.
ما في النك في الفيمر.
يا سيدي.
هذه ما في neck.
head fracture.
Okay, the X-ray, as I told you, is always standard for both anterior and posterior. Okay, to make sure the axillary view and to know whether it's posterior or anterior. As I told you, it's a Bankart in the anterior, it's a Kim in the posterior, and you have to know them and to understand them and try to reduce it as soon as possible. This thing, I told it for the female, I did not say it for the male bee because we have a short time. It's epicondylitis, or as we call it, the tennis elbow. Yeah. Okay, this is the tennis elbow. It is usually common. I just had a patient yesterday that came to see me. MashaAllah, he's that big. He's that big. And when he talked to you, he's that big, and problem his belly is that big, come on, okay. Doesn't match, صراحة. عضلات that big, and he's thinking, and he's walking that way with his kirsch that big, okay. It doesn't match. I have to eat. صح, you have to eat. Why are you here? I have a pain in that area. So exactly, when I came, you examine him, you put your finger on the radial head. Radial head. This is the radial head. It's the connection between the epicondyle, the lateral epicondyle, and the radial head. And this is the joint, the epicondylitis, okay? Usually because what we call the extensor muscles, the extensors muscles. And those people, what they are doing, they are playing athlete, they want to have a high extensor. They do this and they do this movement. So this movement will cause epicondylitis, especially if you are right-handed. When you are writing sometimes, now put your hand on your elbow, start moving the writing way, okay, you can see it's moving. This can cause epicondylitis, okay? You are walking and you hit your elbow accidentally. So how do we treat those things?
Physiotherapy.
Nah?
Physiotherapy.
Number one, excellent. It's this is for you. Here are some of yes, okay. Okay, this is okay. Physiotherapy is number one. Physiotherapy, and before physiotherapy,
pain management.
Before pain management, tell them to avoid the cause of pain.
Which is the repetitive strain.
Exactly,
yeah.
Okay. Those crazy mentality, I have to train every day 2 hours. Come on, for God's sake. ليش? Training is 2 to 3 hours per week. The other, diet control, simple stretching at homes, okay? Amma, 2 hours every day, are you going to be a bodybuilder? طب ماشي حال, I'm not against it. I love the nice body, the muscles والكلام هذا كله. I was one of them. I injured my hand, I injured my shoulder, I injured my ankle, but I did not stop. Okay, the thing is right now, what is your future? Your future is a surgeon, okay, not a bodybuilder. You can keep on playing sports, you can click on, but it's not your future. One day you're going to be squeezed in the OR. One day you're going to be squeezed over there. So do not dedicate for those things. Who's filming me?
Recording committee.
Anyways, I don't care. فالمهم الشغلات هذه كلها هاي حركاتكم انتم عادة. المهم this thing happen usually. فانت you want to reach a level. The muscle has a limit. One day your muscle is going to be shifted to fat. Why? Disuse atrophy. The big muscles that you created are going to be subside, shrunken, redundant skin, and then this is really ugly. So you don't need to be overworking and do not injure yourself. So physiotherapy is number one. Avoid surgery, and then how do you? خلاص, I'm in severe pain. I cannot stop.
Conservatively with anti-inflammatory.
Number two, okay, and then.
So يعني our target is pain management.
Our aim is to not give any steroids or anything else. Pain management, شو اسمه physiotherapy, avoid surgery, but خلاص he's in severe pain, خلاص he's persistent. I quit everything, I still have some pain. طيب ماشي الحال. The one who said operate, okay, would you like me to operate on you before anything else? Start step by step, okay? Anti-inflammatory medication. Then what we're going to give them is steroid injection, cortisone. By the way, everybody's afraid of it. Don't be afraid of it. Why? Because whenever I give you steroid injection over here, this is going to be located over here. Upper part will not be affected. Lower part will not be affected. Will not cause osteoporosis. Will not cause تسمين والكلام هذا كله.
Yeah.
This is all nonsense thing that has been said all over and all over.
Doctor, can I ask a question? I read in the board books that this type of therapy is considered controversial because it only provides very temporary pain management. So the patient is more likely to overuse this injured part because you're only providing a temporary solution.
شوفي, let me tell you something, okay? My job, your job, everybody's job, okay? When we are treating patients, 50%, 50, and that's a huge number, 50% of the treatment is mentally, not medically, not surgically, not anything you do. If the patient understands what he has and what he should avoid, what he should, he's already 50% cured.
Yes.
The other 50% is your job.
Okay.
But so this is the difference between a good surgeon and a bad surgeon, or a good doctor and a bad doctor. But this is the medication, take it, you'll be okay.
Yes.
But I don't know, what do I have? This is the problem. Our people come to see us, but why am I taking this medication? Okay, the doctor came and saw me for 5 minutes and he disappeared. This is wrong, guys. You have to stay with the patient. You have to give them some time. Treat them like a family. Give them some good advices. What you said is correct because the patient doesn't understand. Nobody told me.
Yeah.
That's the only thing. You did not tell me not to go back to sport. You did not tell me not to play.
Okay.
So you told me to do physiotherapy. خلاص سوي علاج طبيعي وإن شاء الله وأنت طيب. بس.
Okay.
Patients are going back because they are not educated. So this is part of our job, is to educate people and to tell them about their problems.
I have one more question.
Sorry.
What does يعني in the recommended treatments for this particular, for lateral epicondylitis, there was something اسمه ultrasonic something.
Shockwave therapy. Tenotomy.
Yes.
Okay, this is surgically. This is surgically. The thing that you go in, خلاص, when steroids are not functioning, where everything is not functioning, it's an inflamed area. You go in, you do a simple incision over the epicondyle.
Yeah.
You visualize the tendon. Okay.
Through
You can do it through scope.
yeah, but
okay.
what was mentioned انه through like ultrasonic waves, which is basically يعني
هذا physiotherapy. This is physiotherapy.
Okay.
Ultrasonic sounds.
Yeah.
في عندك ultrasonic sounds، في عندك shock wave therapy، في عندك هذا كلها، في aqua therapy، في كل هذا شو اسمه. بس في another surgically, okay, that you do an opening, you visualize the tendon. After visualizing it, you do tenotomy for the tendon. You don't cut it completely.
Okay.
You cut the over-tensed area,
Yeah.
okay, and you inject anti-inflammatory in it, and patient will be doing fine. But this is last on the list.
Okay.
Never been done. يعني I did it less than 10 years ago. Don't. It's not a common thing to be done.
Okay.
طيب, second thing we spoke about كمان الcarpal tunnel. About which nerve we are talking about? Yes. Thank you. Okay. This one, okay, it's always surgically. It is always surgically. I mean, it's a simple incision that you do it and it's treated easily and done very well. Duchenne tenosynovitis, it is something very, very common and usually neglected because people doesn't know what to do, okay? But you have to know the tendons that we are releasing or what are they? You have to know them very well. I'm not going to tell them, okay? But it's usually happening in the sniff box, area. So those things has to be done, and it's done very well. And I told you about the guy that I operated on him.
Which one?
A guy, one of the relatives came to see me. Okay, we were having a dinner gathering, so he was having fun. Look, I have pain in my wrist. Okay, so I just examined him. You have the pain. Need surgery. لا يا شيخ. Yes, you need surgery. I've been suffering for the last 2 years of it. I've been to here. I told him, we have to do it for you. He came to me next day. I just opened. It took me 10 minutes, 15 minutes surgery done. Alhamdulillah, patient is fine. He was completely cured, 100% on spot. Yani next day, he's moving his hand, happy, very happy. What did this stupid guy do? الغبي, I'm saying he's غبي because he is غبي. Okay. He's my relative, by the way. Okay, that's why I'm taking my time to talk about him. Okay. Otherwise, I don't say that about my patients. He went for wrestling, and the sutures are still in his hand 3 days after surgery, because he was happy.
اتحمس انه I can move my thumb, so I'm gonna beat the guy in front of me. But he doesn't know, that stupid guy, that he's not using his full power because he's scared to injure his hand. So he injured and he broke his ankle at this 3 days after the surgery. So this thing you have to take care about it. Synovial ganglion, I have a case coming to my clinic tonight, inshallah. I'm going to operate on him. He is coming a young guy. So those things, it's a herniation. شفت الفتاق اللي يصير في السرة أو الفتاق اللي يصير في هذا. It's exactly the same thing. It's a herniation of the synovial fluid that comes out and causes severe pain with affliction. It's more common in female, by the way. طبعا هذولي, this is the keywords. This has to be at the end, so I did not put it at the end. You have to make sure that you read about them. The words that are talking about it. Excuse me. Hello.
مو تعبانة وكل هذا.
كل والله متعبة.
سهري.
صوت جد مرة أصلاً أحول أنا بشغل شغل.
لا توصل شيء شوط يلا رجع
أنا مرة
طبعا هذول هنا الكلمات. Okay, those are the phrases that the patient is going to come and talk to you about and tell you about. Just read them, get back to you, because then you might have those words added to your questions in your exam. ACL anterior cruciate ligament, the percentage, and how does it happen. I'm going to go fast because you should be expert now in ACL. And how many bundles do we have? And their length and their size as well, you have to know them. And the most important part, where do they start from, where do they end? Okay, this is the thing that you have to, and the mechanism and the blood supply as well. You have to understand it. Okay, the mechanism of injury, how does it happen? Okay, and jumping, landing, hyperextension. Okay, with changing in direction. 3 lines, popular, never be changed, worldwide. Everybody knows them. Pop, swelling, knee gave out. Okay, those are the things that you have to understand. It. And hemopharosis. X-ray, usually useless. MRI will show us some bone bruise. Okay, bone bruise. Okay, I might not tell you about the history, but I might show you the MRI. Okay, know about it. What's your differential diagnosis? Clinical examination, you have to know them. Anterior drawer, Lachman. Okay, pivot shift test. Those 3 tests. Okay, those are the things that are important for ACL reconstruction. Okay, as I told you. How to approach them, this is the most important slide. How to approach them, what you're going to tell the patient. Can he go back to sport? Can he go back to the gym? Where should he go? What should he go? And how to do the proper management at the same time, okay? Can I sit, okay, knee immobilizer, okay? Send him for examination, x-ray, okay? No fracture, don't fix it. Okay, there is a fracture, you have to seek something else. No fracture, physiotherapy, knee aspiration, all those things. Everything is written over here, so you have to take care of it nicely and properly. PCL, we spoke about it. Command dashboarder injury, how to deal with it, and the history of the patient. It's a dashboarder, and the clinical examination. It's the opposite of the anterior and posterior drawer. How to do it? Usually X-ray. I will not show you anything unless if there is a translation. If it was an isolated PCL, what should you do? Thank you. Bravo عليك. Conservative management of PCL. Say if it was combined with other things. You said something good. Okay, start with the lateral. Thank you. Start with the lateral, then goes inside properly. Allah يبارك فيك. This is exactly what you do. Menisci, okay, I'm going to talk about it. I skipped the laterals because they are a little bit complex and sophisticated. Okay. You have to read them, you have to know about them. Meniscus, the composition of the meniscus, what is it composed of? What is the shape of the medial, what is the shape of the lateral? And they are considered as the door stopper or the shock absorbers of our menisci. طبعا I was with the students of Princess Noura last week, okay, and I had a total knee replacement. So I showed them on live, okay, the meniscus.
Wow.
Okay, I showed them the meniscus. I showed them the red zone, the red-white zone, and the white zone. One of the students said something really crazy, but I admired her, okay, for what she said. She said, "Doctor, can I touch it?" I said, "Sure, you can touch it. It's out. So I'm gonna throw it." So she touched it. "Doctor, can you do a tear in the meniscus?" I did a meniscal tear. طبعا when you do a total knee replacement, lateral meniscus عادة it's usually still viable, okay? But it is degenerative, so I did a tear for her. So she said, "Teach me how to suture the meniscus."
Wow.
Wallahi, I was really impressed, Sarah. She's asking, there were 10 girls, Sarah. She was the only girl who came and told me, "I want to learn how to do it." Those spirits, those nights, okay, when you encourage, it's not your time. When you kick her out from the first time, she's going to hate orthopedic completely. Okay, so we brought it, we brought an expired suture. I'm not going to waste money on this thing. An expired suture, and she did the meniscal repair, and she took a picture of it. She sent it to me. She's really, really happy about it. So this is the thing, okay, you can see them. Okay, by the way, I'm going to tell you another good thing at the end of the presentation. طبعا المنسكس injury, okay, المedial meniscus occurs where? Where is the most common meniscus injury? أكيد media. Okay, but when? To whom? Obese. You said something. Contact. لا. المedial meniscus usually happen jumping and landing. Okay, isolate. Which is more common, medial or lateral? Medial. والlateral متى بيحصل؟ When does it happen? With the ACL. برافو عليك. It happens with the ACL. Lateral, okay? طبعا there are different types of meniscal tear. We're not going to talk about it. It's really complex. It's another different lecture. I have more than 3 hours presentation about the meniscus. Okay, it's not for you guys. The thing is right now, medial meniscus, okay, it usually happen in obese people with a varus deformity. It usually happen with jumping and landing on the knee, and usually happen with elderly people more than young people. There is an increase in osteoarthritis. طبعا you have to know, when we do a meniscectomy, we are increasing the percentage of osteoarthritis in the knee. Medial count. 25 in the medial side and 15% in the lateral side. Meniscal injury, you have to go through, read them. The type of test, you have to know it very well, McMurray test, okay? And usually the lateral meniscus with the ACL. X-ray will not show anything, okay? Usually it's MRI. I operated on a patient last week, a man, okay, young male, who came to see me walking this way for the last 6 months. Okay, he's a crazy football player. He wants to play football. He keeps on playing on his knee. Okay, he thinks that he's going to be Ronaldo one day, but he will never be. So exactly the same view that you see over here. The meniscus was flipped, went down, okay, and was repaired. Fine. Next day, post-operative, patient is walking normally. But can I go back to play? Thank you. When can he go back to play?
6 weeks.
6 weeks. You're so generous.
Well,
6 months.
At least he has to reinforce. You have to strengthen the muscle. Okay, 6 weeks. Okay. But how to fix it, how to repair it, it's none of your business. Okay. The ankle sprain, we spoke about it. The anatomy, you have to know it. The AFTL with CFL. Okay, you have to know them very well. And AFTL, CFL, okay, and the deltoid ligament from the medial side, those things, the mechanism of injury, how does it happen, how to deal with them, and the symptoms and clinical presentation, swelling, inability, okay, swelling, bruising, tenderness, finding depend on the severity of the injury. Presentation and symptoms and sign, how does it happen? لابس كعب في الحفل وجالس أرقص، okay, طقة الروح، طقة الكاحل معي. This is the most common presentation, okay? الميل, okay, usually I'm going down, jumping, running, التوت رجلي تحت الكدة in football. This is something that can happen a lot. Okay, clinical examination is the most important part. I had a female that came to see me yesterday. She is 80+ years old. She was walking and she twisted her ankle twisted her ankle. When I saw her yesterday, she came to see me 10 days after. No swelling, no anything, no. How would you approach her? 80. X-ray normal, MRI normal, كل شيء. But there is pain at the AFTL, at the insertion of the at the anterior fibular ligament. How would you deal with her? It's definitely conservative. But what type of conservative?
Bracing.
Thank you. Bracing is the most important. What type of brace?
Fixed.
We can do that, okay? We can apply cast, we can apply multiple things, okay? Those are the things that can happen, and the most important part that this thing, okay, you have to fix it. There is something called elastic bandage, sticky, it's called tensoplast. You apply it, you can see it, and it's gonna be fixed very nice, and this is what they need. Elderly people, you want to do something, relieve their pain only, and keep them walking. You don't wanna do something that's gonna put them down. The elderly person, when you put him down, he will never stand up again. So you need to keep them. You need to keep it in mind every time this thing. Okay. Ankle X-ray. Okay, this is for investigation. Definitely, as any other thing, ice is number one for the ankle. And for this is, you see this type. This is the type of the bracing I'm telling you about. It's elastic and it's sticky. But it should not be, it should be in 90 degree. You have to put the ankle in 90 degree and fix it, not in this position. طبعا, okay, multiple things. We have the air cast boot. This is very easy, very simple. You can apply as well command steroid injection if the patient is really in severe pain. And you can aspirate if there is any fluid. نيجي to my last thing in my presentation is that, it was this the last thing, صح ولا لا?
Yes.
Yeah. The degenerative osteoarthritis, you have to know the alignment, the normal, the varus, the valgus, and you have to know something as well. You see, I jumped directly to the point, okay? I'm not gonna go, but see, you have to read the presentation, okay? Allah yakalikum. Stage 1, 2, 3, 4. Stage 1, joint space mild narrowing, subchondral sclerosis. Stage 2, okay? Decrease in joint space, subchondral cyst, as well as you can see over here, okay, more narrowing. How do we deal with stage 2? Stage 1, okay, conservative painkillers. Stage 2, young, healthy, no signs of osteoarthritis, بس في narrowing واضح. By the way, this patient is not in severe pain, but he's pain when he's walking for a long distance. He is pain and he has varus deformity. Corrective osteotomy. What do we call it? HTO, high tibial osteotomy. Okay, this is the bowing or the varus that you can see. I want to unload. Why does he have narrow space? Because the weight is always on the medial side. So I want to unload it. Okay, you do corrective osteotomy. So you break the bone and you correct. That's what we call high tibial osteotomy. Stage 3, it's more narrow. Okay, bone cyst, osteophyte, and sclerosis. Stage 4, خلاص, it talks about itself. Okay, you can see it very nice over here. That the bone cyst is very all types, narrowing, bone cyst, sclerosis, and osteophyte. Clinical pictures, they're going to come with pain, increase with activity, standing, decrease with rest, analgesia, worse at the end of the day, and they cannot sleep at night. Symptoms: limping, walking with distance, using stairs, walking aid. Okay, they are not praying on the ground anymore. They are praying on the chair. Okay, type of the bathroom. We cannot have a killer. You have to go through it. If the patient is diabetic, if the patient is rheumatoid arthritis, you have to know about it. Past surgical history, meniscectomy, and all those things have to be taken care of. The workup, البلاد والسواب والشغلات هذا كلياته. But the most important part is this. Every time, this is the last lecture, the last slide, guys, by the way, okay? Every time, you have to know both knees standing, AP and lateral. Don't do single knee. Never, ever do a single knee. One patient is complaining of his right knee. Okay, you do X-ray for his right knee. So you ignore completely the left knee. When you do the left knee is worse than the right knee. But because the left knee is worse, he's weight bearing more on the right. But you don't know, if you operated on the left, the right knee will be okay. So this is a mistake that you have to know. Both knees, standing, AP and lateral, skyline view to see the patella and to see if there is any osteoarthritis or loose body. خلص. We still have 1 hour, I know. But I told you we're not going to take 2 hours. The thing is right now, أي سؤال from anybody من المحاضرات. If you have any question you want to ask, it's your time now to talk. This is the X-ray that I was telling you about this morning. شايفين؟ شايفين الديستنس؟ الجاب؟ Oh, it's a nice nail. It's good, it's centralized, it's in place. Patient is moving, flexing his knee smoothly. But there is a gap and there is pus coming out. Literally, it was disaster. So, what did I do for him?
Take out the
What did I do? Oh, it's just showing you. So, I removed the nail, and then this is the lateral view. شوف lateral view. Lateral view يحزن اقسم بالله العظيم بشكل غير طبيعي. So there is something over here. What do we call this thing? هذا الدائرة هذا this thing over here. So let me show you in this view better. This one. هذا this one, the circular one around the nail. Huh? Me?
K9?
It's not K9. Okay, I know what you want to see. You want to say K wire. Okay, it's not a K wire. It's a cerclage. It's a cerclage. At a cerclage, when you see it in surgery after somebody else, that means that doctor did a stupid thing. He broke the bone while going in with the nail, and he opened the bone, so he bring the cerclage to close it together. Okay, so this thing has to come out as well.
What is the cerclage used for usually?
Usually the cerclage is used for two things, okay? If you have, يعني مثلا, you can apply it, but when you apply, there are certain way how to apply it. For patellar fracture, usually, or when you have an open bone, and you cannot close them together, you cannot apply any screw in it, because if you apply screw, it's gonna break more.
Yes.
You go around it, you put it around this, and you tighten it, and it's slowly, because this had a سلاح ذو حدين. It can do something else.
Okay.
What it can do? It can cut the blood supply. If you squeeze it too much, okay, because the blood supply is from the periosteum.
Yes.
When you cut the blood supply from the periosteum, well, there will be necrosis and non-healing and no in this area.
We can use it in the open book fracture.
The open book fracture for example, it is in the pelvis.
So we don't use it.
You use a binder from outside. Okay, and there is another. Okay. This is another patient. Okay, this is the patient right now. This is the patient right now. طبعا, I had to open the wound. I will show. Do I have the wound over here? Just a second. Yes, this is the wound before. هذا المريض is walking for the last 1 year this way. Pus is coming out with a lot of hair around it, so it was really ugly, really dirty, and it has to be cleaned and properly. So, this thing, okay, this is the patient right now. Nail is out. What do we call this device over here?
External fixator?
Bravo عليكي. It's an external fixator. I had to fix it from the top, fix it from the center, but I did something else. Who's going to discover it?
You removed the, you broke
You remove the
What?
cerclage.
from the beginning.
There is a broken
From the distal part, beginning. مو beginning ما في beginning or end. طيب can you tell me where is it؟
Yeah.
هنا هذه why؟
So we can hear it.
Thank you. This is the case report. Why? This area has been 1 year infected. I cannot put bone graft. I cannot put bone cement. I cannot put anything in it. It has to be open, has to left open to heal by itself. And I broke the bone from the distal part, so it's gonna go up, 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 up. So it's gonna narrow that area. Patient will be on an IV antibiotic, and we're gonna see him. But this picture, what you can see right now is something much better than when we, it's not very clear over here, but it's clear on my phone, okay. There is some callus formation over here. This callus formation was unable to heal because of the infection, because of the K-wire. Now, K-wire is out, عفوا, the iron nail is out, كل شيء كان طلع منه. And we're going to lengthen it from here, and inshallah ta'ala, patient will be doing great.
Inshallah.
Now.
Is this approach you were talking about, is it the same approach used in patients who wants to increase their height?
Yes, and this is my presentation. This is my. Oh yes, شفت الكسرة كيف كانت? It's exactly that's exactly. This is the lengthening. This is the SZ osteotomy. We broke it from distally, but you can use it for trauma patient. It's not necessary. This is exactly what we were talking about. Okay. Any other things you want to talk about, guys? Now.
For the knee dislocation, do we say anterior or posterior according to the femur or the
Tibia. The distal, all of proximity. Okay.
So when the tibia goes
Anterior dislocation. خلصتوا؟ نعم. Yes. Delay ايش؟ Anterior cruciate? بعرف نفسي اسويها اليوم. But sometimes patients they are coming with a swollen knee and their knee is stiff. You need to give them some range of movement. You can delay 2 weeks, 3 weeks. The golden period is to be operated in the first 5 months. بعد 5 شهور, okay, it's going to be risky. Usually. But it is done easily. I don't delay, never delay. The patients are coming late. Me personally, I don't delay the patient. Okay? خلصتوا؟ طيب. And I have a physician who works with me in Princess Noura. Okay? She's a gynecologist. تفضل.
Okay, can the T-Gordian tenosynovitis symptoms happen in the other fingers?
In the other what?
Other fingers.
And the other thing is called tendinitis, and it's called trigger finger sometimes. Okay? It's whenever it's called trigger finger. It's not not a degree. Okay. I promised her. I met her. She's the head of gynecology in our department, and I heard that her daughter is with us. I don't know who she is, صراحة. But she talked to her mother and she doesn't talk to me. Anyways, have a good day, guys. Okay, by the way, I left my hat. By the way, I know that I'm not responding to some people on my phone. I know that I'm a bit busy, guys. This is my name. You already have my number. And this is my email, my professional email. So we can talk anytime you want or you can do anything you want. By the way, the presentation موجودة على the presentation موجودة. Have a good day.
والله